presentation by Dr. Pawan Kumar. Current concepts. Current concepts on revision ACL reconstructions.
Thanks.
Yeah, hi. Good evening, everyone. I'm Dr. Pawan Chabi. So it's more of it's more of a current concepts, more of case-based, two of them case-based, but most of it is about what exactly goes in, or what exactly do you expect in a patient with a failed ACL reconstruction. All right. So there is an increasing incidence of ACL reconstruction, as we all know. So an approximate of about 1,25,000 ACL reconstructions are done in India, compared to 17,000 in Australia, and on average of about 300,000 in the USA. So of course you definitely will expect a high rate of revision. So what is a failed ACL reconstruction? A failed ACL reconstruction is when a patient with a ACL reconstruction has, over a period of time, develops instability, pain, with or without stiffness. So if someone with a post ACL reconstruction has these three, or any one of these over a period of time, that means it's a failure of the reconstruction. So is a revision ACL reconstruction challenging? Yeah, it can be, because there are limited graft options. The anatomy is altered. There is a dilatation of the tunnel, which always will encounter. Always there will be associated injuries around. There will be a malalignment issue as well. But of course, it can be successfully overcome if we identify the cause of failure of the original ACL reconstruction. All right, so most important question, why do ACL reconstructions fail? Yeah. Most importantly, it is the technical errors, that is, which amounts to about 64 to 83% of the failure rates, especially the femoral tunnel. If the femoral tunnel is not got right, that is the highest chance of failure of a ACL reconstruction. Next is graft impingement, that again is because of malpositioning. Most of the time it could be because of some remnant of the previous ACL left, or if the ACL graft tunnel, femoral tunnel is malpositioned, invariably in extension it will cause impingement. Next is recurrent trauma, that is high demand activity, recurrent sports, recurrent early, when patient goes back early to early sports before the rehab is complete. Biological failure, it accounts to about 6.4%, where poor graft incorporation happens. I've seen this with some biodegradable screws, sometimes with metallic screws as well. Infection, not to be ignored. Of course, infection is an important reason for failure. Everything will be fine. You get an infection, you treat. Somewhere the graft loses its structure, the joint becomes stiff, and then ultimately it leads to a ACL failure. So infections are not uncommon. It do happen. You have to be careful with them. And of course, already discussed the tunnel malposition. Okay, so what is the preoperative planning in case of a revision ACL? So first of all, we have to review what the primary surgery, what was done exactly. So what was the graft which was used? Where is the tunnel? Is it right anatomical tunnel or not? What type of fixation was used for this? Whether the patient had any complication, a detailed history will tell. Any early complication, maybe a small little infection in between, a late complication where he had a small trauma, or there was a injury or something like that, whether the rehabilitation was complete or no, all those things. So clinical examination is very important. Here, clinical examination gate in which we see how the patient walks, whether there is a varus thrust, whether there is a hyperextension, fixed flexion deformity, whether the patient there is some sort of apprehension in using that particular knee, etc. All these things can be known in that. Scars which tell about where the graft was taken from, whether there was any infection in the past, etc. Range of motion, again FFT, hyperlaxity, etc. And stability in all directions. This is very important to know whether there is not just the latchments but the other tests also if there is an issue with the stability. Imaging which follows, where you have your standard X-rays, CT scan to get a tunnel positioning. Also, if you can request the radiologist to, do a proper calculation and give the amount of dilatation which has happened of the tunnel, and what is the measurement of the tunnel. It is very important. And MRI usually is done to see if the graft is intact or no. If the graft is torn, if the graft is still intact, whether there is a cyclops lesion or something like that. If there is an associated meniscus injury, cartilage injury. Also, we have to rule out infection by getting the inflammatory markers, if necessary, an aspiration. All right, so I'll put up this slide later again in the end for all to look at. So what are the graft choice in a revision ACL? Autografts are almost always preferred because of healing is supposed to be complete, and autografts there is a less chance of re-tear. So autografts, especially first preference will be a bone patella tendon bone graft, then quadriceps tendon graft with one part bone, hamstrings and peroneus do follow. Allografts can be used in multi-revision scenario and multi-ligament injuries and in low-demand patients. But then again, there is a high chance of re-tears in these allografts. Ideal is, as I said, bone to bone, where bone patellar tendon or quadriceps tendon can be used. Secure fixation is important because here already the bone is compromised, the muscle is weak. So if at all you require to secondary fix, secure the fixation with secondary fixation, maybe a civil lock or something like that, it has to be considered. All right, so there are different types of revision. You come across different types of ACL revision scenario. So in a single stage revision, when is it preferred? When do we do a one stage revision ACL? If the tunnel diameter is less than 14 mm, if they are anatomical tunnels with no or minimal non-anatomical tunnels which are less than 40 mm, anatomical tunnels with no or minimal dilatation, where retrilling with a larger graft is possible. So if there is an 8 mm tunnel which is anatomical, but still it is small enough which can accommodate a bigger graft, then we can do a single stage revision ACL reconstruction. So here there is a outside-in technique in which you can change the trajectory of which we do in all inside ACL reconstruction, where you can change the trajectory of the femoral tunnel so that you can get maximum bone to incorporate the graft. Can be used. Bone blocks can be used. You can get allograft from the femur to fill up that. If you have a snug fit into the tunnel, you can do that so that at least some amount of surrounding tissue will be there for the graft to incorporate. Larger intervention screws also can be tried, and there's another technique called as over-the-top technique. If anybody in the panel have used this technique, or any other colleagues have used this technique, in which there is a ACL reconstruction which completely misses the tunnel, comes from behind where it is secured by staples, and the same thing can be used as a LET as well. So you can do two things in one. So, but then I don't have any experience on this. I've never seen one. Just came across the paper. And then there is a single stage bone graft. That is the same thing which I told you, where you can put allograft towels just so that you get a better surrounding bone tissue for the graft to get incorporated. When do we do two-stage revision ACL reconstruction? If there is a severe tunnel dilatation of more than 14 to 16 mm, partial anatomical tunnels, if there is an infection or arthropfibrosis. So in the first stage, there is so basically infected, non-infected. That's categorized as it's not there in the slide. So if there is infection, then you clear the infection. Make sure that there is a thorough debridement done. There is no amount of debridement. All the dead tissue, everything is taken off. Graft is taken out. Wait for some time. See if the infection settles down. Then do another stage, and then see if it requires a two-stage from there on. If there is no infection, then you curettage the tunnel, you put a bone graft completely inside, and you have to wait for at least 4 to 6 months to make sure that the graft is completely taken up. Here, you have to confirm it with a CT scan and then check if the graft is taken up or no, and then we'll have to see that whether the patient is fit for a second stage ACL reconstruction, the revision ACL reconstruction. And of course, you need to make sure that the graft fixation and biology is good. So this is the two-stage reconstruction, ACL reconstruction. Additional procedures are almost always required. Till now, in whatever revision I have done, there has been additional procedure which I have done. So osteotomy is if there is a varus of more than 3 degree as compared to the other knee, and if the slope of the posterior tibial slope is more than 12 degrees, then an correcting osteotomy is necessary. Meniscus root repairs or transplantation may be required. Cartilage restoration is required. Rotational stability, you can do your LETs and reconstruction. And of course, if there is a associated MCL and PCL injuries, has to be addressed. Osteotomies, as I said, if there is a varus deformity of more than 3 degree as compared to the other knee, then you have to consider a osteotomy along with the ACL reconstruction. If there is an increased tibial slope of more than 12 degree, it's one of the strongest predictor for an ACL tear. So even in a primary scenario, if there is if there is a suspected increased tibial slope, then you have to consider a osteotomy along with the ACL reconstruction. So it's pretty easy now to do these surgeries in single stage instead of doing it combined, two-staged osteotomies and ACL reconstruction. So extraarticular procedures, be it revision ACL or be it primary ACL reconstruction, always make sure that you see the Brighton score, hyperflexibility of the patient, and make sure that the person has some amount of, if at all he has too much of ligament laxity, then you consider extraarticular tenodesis for him or her. So here again, in revision scenario, it's a very useful procedure. And this ensures, it kind of gives a security. The patient feels immediately secure after, in the post-operative phase after a revision ACL reconstruction. Because already they'll have this loss of proprioception, and when you do an LET with an ACL, revision ACL reconstruction, they get that confidence. So here, Lemaire's procedure, the modified Lemaire's is what I prefer to do. And it definitely gives that confidence in the patient and protects the graft from being retorn. So meniscus and cartilage in revision ACL reconstruction, of course, in ACL deficient knee, the medial meniscus is almost always torn. Yeah. In a fresh ACL, when you get a fresh ACL tear, there is a lateral meniscus tear, usually in the posterior or middle horn. But if there is a ACL deficient knee, the medial meniscus is usually torn. And if it is a ACL deficient knee, and the person is contemplating on a surgery, if there is a time which takes, then the root test ultimately happens. So in this case, you need to make sure that you do a root repair And if there is any, and most of the times you get patients who have done ACL reconstruction, and the primary surgeon has also done a meniscectomy where they have pretty much taken off the whole meniscus. So you may have to consider meniscus transplant, allograft transplantation also. And of course, chondrofillers and oats and other techniques can be used if there is a cartilage loss. So just two cases I want to show of revision ACL. So this was a 30-year-old male who had an injury, who was actually a volleyball player. Now he doesn't play anymore, but he was a volleyball player, and he had a ACL reconstruction while playing volleyball with an MCL and a medial meniscus tear. So he had a ACL reconstruction done 3 years ago with a meniscus repair and a medial meniscus balancing. So after the surgery, he persistently had a discomfort and instability, and he said that he was never happy with the surgery. So here you can see there is a malpositioning of the tunnel. The tunnel goes, the trajectory of the tunnel is goes anterior, and the button is sitting on the anterior lateral aspect of the femur. Yeah, you can see now. So the trajectory of the I think it's not working. Anyways, so here you can see this is the graph. The graph, actually, we got an MRI and the graph was perfectly fine, no problem. So it goes from here and it goes somewhere over here and goes in front like this. So he never felt normal. And he had an associated small little meniscus tear in the posterior arm, which I stitched. So basically, what I did for them is I did a revision ACL reconstruction with a bone patellar tendon bone graft with the extraarticular tenodesis. So the position of the graft was completely non-anatomical. So I had to, there was no problem for me to get an anatomical tunnel in the right place. So it was very easy to do that. So I fixed it. I did extraarticular tenodesis on the side. He is much more comfortable now. So he's returned to active gym and he does all his running and light pivoting, back table tennis, and other things, and he is symptom free. So next one is a 60-year-old retired policeman. Problem with the left knee. He had a primary ACL reconstruction done about 1 year ago. So 60 year was probably in his late 50s. He got a ACL tear. He got a ACL reconstruction. He came with a symptom of instability and medial knee pain. So on examination, he had a varus thrust gait. He had a varus deformity and gross laxity. So he had on an MRI, the graft was completely ruptured. There was a medial meniscus root tear, and also he had a varus deformity on the particular knee. So ignore the right knee because he already had a varus deformity here, and it never troubled him. And the main problem was the left knee joint, because the left knee joint was perfectly fine. He had an ACL tear. He got an ACL reconstruction, and the varus deformity was not addressed. So he came to me for the left knee joint. And the right knee joint, it was a slow varus which was going on, just like a slow rotator cuff tear, which is non-traumatic. It just kept going on, and he never had a problem over there. So he came to me, and what I did is I did a revision ACL reconstruction with a root repair and a ITBL osteotomy. So now I addressed that alignment issue as well. I addressed the root repair, that is the meniscus repair, and the ACL reconstruction. So this is the operated knee. This is the other varus knee which is not troubling him. So he's doing perfectly fine. This is about I would say 8 months post-operative. So left knee is the troubled one, which I did ACL reconstruction and alignment. This one, the right knee, I told him that he will require a total knee replacement. He said that when I'm ready, when it really troubles me, I'll come back. That time you can do a knee replacement. This is what he told me. So, what is the outcome in literature about revision ACL reconstruction? So, it does restore the stability, but always it is inferior to a primary ACL reconstruction. Return to sport after a revision ACL reconstruction is up to 40 to 50% at the same level. You may have to change your sport after a revision ACL versus primary ACL where more than 70% we can guarantee a return to sport. So there is a risk of arthritis and re-rupture after revision ACL reconstruction. And of course, we need to have the counseling skills and need to know what exactly is patient's expectation, etc. So in conclusion, a revision ACL reconstruction is challenging, but an effective procedure. It requires planning and you have to address all the causes of failure. You have to know exactly what you're looking for, what is patient's expectations, and what is the actual reason for it to fail. And it does almost always it involves adjunct procedure. You might require HTO, LET, meniscus repair, cartilage implantation, slope correction, something or the other. And you need to make sure that the patient knows that his knee is undergoing a revision surgery after ACL reconstruction, and there has to be some limitations which he also needs to agree with, and then go ahead with the procedure. So these are the references. This is just an algorithm. This is very easy to understand. This is by Dr. Sachin Tapasvi. It's very easy to understand. Very simply, it has been put out over here. I'll just leave it over here. Thank you.
Any questions?
Any experience with the valgus knees?
Valgus knees with the ACL test. Yeah. It was bad. Here, MCL which was ignored. They had done the repair of MCL, but it failed. ACL was there, so I did a MCL reconstruction for him. His ACL was intact, so I did not touch it.
I have a question.
Yes.
The correlation between virus, I can understand the posterior slope of 20. Correlation between virus and failure of ACL. And you mentioned that it's 3 degrees virus. How do you correct a 3-degree virus?
3-degree virus as compared to the more than the as compared to the other knee.
Yeah.
So if there is,
so let's say the other knee is neutral, and you have 3 degrees virus in this. Would you still go ahead and